Hello and a warm welcome to New Money. I'm Brian Hurst. This evening we are focusing once again on the healthcare industry. Members of medical schemes are overwhelmed by the different choices available to them and their families. It's often the case that the costs are the main considerations without fully understanding the benefits of the healthcare needs of individuals. Every medical aid is structured differently and individuals should choose one that meets their healthcare requirements. And joining me this evening is healthcare expert Clayton Samsudini, Group CEO of Phoenix FSG. Clayton, good to have you on the program.
Good evening. Thanks.
Clayton, are there too many choices?
Yes.
Too many medical, although there's been a consolidation over the years in medical aids, but within the medical aids there's just so many choices.
Yeah, no, I'm in total agreement with that. There are too many options. But I think what's making it worse is that medical schemes, we've seen a trend where if they need to increase a particular medical scheme's option, they realize this premium may be unaffordable for members in that particular option, then create something as a lower option as a default. So we see members then defaulting to that specific lower option. But over time, like what you've seen this year, is that option starts to consolidate within a medical scheme. And that starts to prejudice members simply because there will be a sacrifice somewhere, either lower benefits or a higher contribution. And like we've seen when medical schemes combine or consolidate, the very same argument applies when medical schemes start to consolidate options.
So Clayton, some time ago we spoke about NHI, the bill waiting for the minister to sign off. We've got an election, it's hard to believe that the election actually today is around about 6.5 weeks off.
Correct.
We haven't heard anything about NHI. We always thought this may be a political announcement and to help, but we haven't heard anything. Are you expecting anything?
Well, as we're speaking now, the President has not signed off the bill yet, and you correctly, I think, 6 weeks away. And you're correct, this was an election promise by the ruling party. And then towards the end of last year, total confusion. We had the Deputy President saying, that there needs to be more consultation. And then we had the Minister of Health saying that, perhaps there are other options to look at. So your guess is as good as mine as to whether that bill will be signed before election date. But that's very unfortunate. And I also think that we're far, far away from implementing NHI. It's not a switch that you can switch off private healthcare and switch on NHI.
Yeah. Clayton, this NHI, I always thought to myself, maybe low-cost schemes and maybe NHI is the reason. But that's not the reason. I mean, the Council of Medical Schemes seem to be dilly-dallying enormously about low-cost schemes, and isn't that what's required? I mean, NHI, even if it's implemented, it's going to take years to come into fruition, but members do need some sort of cover.
Correct.
So what is happening with these, and why the delay?
So I think there's a massive gap between what the Minister of Health is attempting to do with NHI and what the Council of Medical Schemes intends to do with this low-cost benefit options. So if you think about it just logically, you have a scenario here where NHI is going to be the single funder, and as we understand it now, medical schemes will not be able to provide for benefits that's provided by NHI. So you're going to just complicate the whole healthcare landscape if you were to introduce a low-cost benefit option now that in time is going to be replaced by NHI. So I think that is why we have this continual delay and delay and delay. And once again, as you probably have seen, it's now been again extended to the 31st of March 2025. And although
so there's no immediate decision.
No.
There's now another year's delay.
Correct. So all primary healthcare products that have received exemption from the Medical Schemes Act a few years back will be allowed to continue in the current form until 31st March 2025. But I wouldn't be surprised if we have another extension or two until we understand where NHI is going to fit and medical schemes or anything in the private healthcare sector.
So we left with what we got. But then what solutions are available to members if they want to reduce their medical scheme? I mean, a reduced medical scheme and gap cover can't equal a medical aid.
Yeah, so I think on the topic of reducing a medical scheme cover, What we're finding is that I think always what has happened is we've done a needs analysis and we purchase a medical aid in accordance with those needs, or what we anticipate to happen, or what could be deemed a hereditary disease like cancer as an example. Now there are schemes in the market that allow you to purchase what you need at this stage of your life, and where you can upgrade to a higher option upon diagnosis of, let's say, a life-threatening disease. So what I'm trying to say is that there are schemes out there that you can purchase at a lower price based on your needs now. If you have a life-threatening disease, you can upgrade. And similarly, there are options where you can tailor the level of, let's say, medical savings that you want. So, you know, there is, I think, a finer balance, more customization taking place. An example of that, one of the schemes that comes to mind is FedHealth. They allow this to sort of tailor-making and flexibility, which I think is really the answer to the market right now. So, you know, if let's say I have, in my family, people have suffered from cancer, I would immediately buy that plan with the highest cancer cover, but I may not contract cancer ever in my life, you know. So for me, it would be better to purchase according to my needs now, with the ability to upgrade later if required. And I think that is the answer, part of the answer.
Clayton, in all my years, I've always understood selection against the company. So it seems strange. Why would I purchase something with bigger benefits if I can pay less now and upgrade if there's a critical or dreaded illness?
So the precursor here is the fact that this is going to be a new diagnosis. It's not anti-selective. So anti-selective means I'm not on a medical scheme, or I'm at the lowest option. Now when I am planning to do certain surgery, I now upgrade. That's very different to being on the medical scheme that I afford, then being diagnosed in the 12 months in the benefit year, and then upgrading because of the diagnosis. That's very different. That's not anti-selection.
And so you say members can manage and plan for the benefits they want.
Correct, absolutely.
And now, so let's just talk about, I mean, we've had a lot of people come and go in the medical aid, a lot of people who've never been in the medical aid. It's quite onerous that you get this penalty when you get to age 35. Because it's a lifetime penalty. It's not just a penalty for a period of time. Like, you know, you're coming into the pool, you've now got a penalty for a year or 2 or 3.
Yeah.
It's an onerous penalty. Is anything being done about that?
Not actually. There's nothing being done by the Council for Medical Schemes, and you're referring to the late joiner penalty now. However, again, you know, advisors such as Phoenix that are contracted to more than one medical scheme, we have kind of offers from time to time from certain medical schemes that allow for members to join up to age 50 without a late joiner penalty. So this depends on, let's just say, the risk pool of the medical scheme, the risk pool of a specific option, and of course the health status of the member. So you could have somebody at, let's just say, 48 and join a medical scheme without a late joiner penalty simply because of health status or the option that they're being joined. Again, this is just, you know, I think testimony to being an independent advisor and not linked to a particular medical scheme, because you wouldn't have that kind of offering to your clients.
And reputable medical aid, a company with good solvency margins.
Correct.
So let's say that I'm a 43-year-old. I'm in a medical aid with a penalty.
Yeah.
Would it be advisable maybe for me to have a look at other alternatives? Because, but I want the same cover. I don't want an inferior cover.
Correct. Yeah.
And
absolutely.
What is the penalty over age 35?
That penalty can go anywhere from 25% right up to 75%. And again, it's about just structuring that correctly. So I want to kind of just mention to you that medical schemes, I think what's maybe not known in the marketplace is that we have an average age of the members covered in the private healthcare. And that average age is higher than 35. So as long as a medical scheme is the ability to maintain its membership below the industry average, then they're sort of happy to kind of make exceptions on the late joiner penalty issue. So remember, Council is not enforcing the late joiner penalty. It's saying the medical schemes can allocate a late joiner penalty. And because of that, it's now up to the medical schemes if they want to add this or not.
And Clayton, how easy is it to change from medical A to medical B with waiting periods and pre-existing conditions periods as well? I mean, if you've been on a medical aid for 5 or 10 years and I want to move from medical aid A to medical B?
Yeah, to answer that exact question, if you're joining without a 90-day break, you will have immediate cover, your chronic conditions will be covered, and you'll have only a 3-month general waiting period. And that would be, in that 3 months, by the way, you'll have access to prescribed minimum benefits. So as long as the member understands the risk period of the change is actually 3 months, you know. But in that 3 months, should you have a life-threatening situation, you'll be covered. You know, and if you understand that dynamic and play that off, having to pay a late joiner penalty for the rest of your life, it could just make sense to do that.
And then, Clayton, we often talk about the medical aids trying to overrule what doctors prescribe treatment is. Doctor says one thing, they say another. Is this where a healthcare broker is this where you would come in and say, and take on that case? Because the public is dealing with call centres and maybe even elevated to someone higher. But this is could be a real problem. I mean, you do have situations now with new drugs in the market where people are convinced that's going to help save my life or a family member's life. And the insurance companies are saying, or the medical aids are saying, you know, is this where a healthcare broker comes in?
Typically, so this would be, let's say, under the banner of extended services simply because of the level of work that is required. However, what would happen is that, you know, what one has to do is to follow the process. The process is the claim gets rejected, you now escalate this to the clinical committee. The clinical committee then gives a final answer, as in whether they're going to approve or reject. And when that happens is then to go to the Council for Medical Schemes and to lodge a complaint there. It doesn't work, and it's not appropriate, and you'll agree, that, you know, at the very first step where a claim is declined, you automatically go to council. First work with the medical scheme until you get to a point where there is no resolution, and then escalate to council. And understand that, you know, if it's within the rules of the medical scheme, then because it's a registered rule, they cannot pay even if they wanted to. However, if it's, you know, then deemed to be a prescribed minimum benefit, council will instruct the particular medical scheme to pay. That process takes around 30 days from the date that you lodge the complaint. So it's not, you know, months, but it's 30 days is a quick turnaround time, I would say. I'm
going to pick up on that when we come back.
Sure.
We need to take a break. Stay tuned. I'll deal with the emails when I get back. We'll be back shortly.